to just drop where you're calling in from or listening from. We want to see, what states you guys are representing, your organization, and see who is online with us today. So welcome everybody. So we know it is the 12 o'clock hour, exactly at 12:01 right now. We want to go ahead and get started and honor your time and appreciate you all being here today for the Lunch and Learn. We're excited just to learn more information about amniotic fluid embolism, which is hosted by one of our amazing MVPs of the Mama's Voices partners, Miss Miranda. We're going to first go ahead and kick off just welcoming everybody to Mama's Voices. We're thankful that you guys are here today. This is, of course, is an informative lunch and learn event. I am Rose Sims. I am a program manager with the Mama's Voices team, and it is my pleasure to welcome each of you here today. So I want to talk a little bit about our agenda today so you'll know how we're navigating the lay of the land. So first, I'll do a quick overview about Mama's Voices. I'll do an introduction of the speakers, and then I'll also let Miranda jump into the meat of the presentation today. So our mission at Mama's Voices is to amplify the voices of patients in any form of maternal health. So our specific focus is to encourage patients to use their voices and to activate change in any space that impacts maternal health outcomes. So a quick note, although we may use gender-specific terms during our presentation, the Preeclampsia Foundation and Mama's Voices program emphasize that all people, regardless of their gender identity, are deserving of respectful medical care. So, for those who may be new to Mama's Voices stands for Maternal Mortality and Morbidity Advocates. It is the first ever maternal health patient advocate program, bringing together real patient and family voices. We're made up of dozens of maternal health organizations who represents all types of maternal health conditions, as well as cross-cutting topics like maternal mental health, racial equity, healthcare delivery, and patient-provider partnerships. We bring together people with lived experiences, healthcare providers, and organizations who are working in maternal and infant health patient advocacy. So we do this specifically by leveraging other maternal health organizations in this space, uniting our shared agendas of maternal health organizations more effectively to advocate and move forward the needle in healthcare practices. We also influence systematic change and more equitable maternal health care systems. So if you run a community-based organization, a maternal health nonprofit, or just want to learn more about our partnership program, you're welcome to scan the QR code located in the right-hand corner. It'll take you directly to our organization pages there. And my
Well,
email address is also there if you would like to reach out to me directly for more questions.
it's not.
So, have some exciting news. In February, Mama's Voices launched the Mama's Voices SUD Research Hub, which is substance use disorder, which was co-designed with women and families who face challenges of substance use firsthand.
I don't have to go to this.
Their courage in sharing their stories help shape better care, ensuring that every voice matters in the journey towards healing and recovery. So you'll find real patients and family experiences that offers insights and guidance for providing compassionate and effective care for those navigating substance use disorder during pregnancy and postpartum. So our first webinar kickoff will be on Thursday, March the 20th, which is actually tomorrow. So you can scan the QR code if you would like to register for our first webinar. So it is my pleasure today to introduce today's speaker, who is the Executive Director of Amniotic Fluid Embolism Foundation, which is a nonprofit organization that she founded in 2008 after surviving an AFE during the birth of her son. She is also a co-investigator for the Fluid Embolism Registry and the Bio Respiratory and I'm sorry, in the bio repository and has authored several publications in AFE and support after severe maternal event. She is a frequent lecturer and serves on multiple boards and maternal health initiative. So without further ado, we will bring Miranda up to present today to you guys. So thank you all for being here.
Thank you so much, Ro. And thank you to everyone. I had asked in chat if you could just share your connection to AFE and sort of what motivated you to come. I know today is a mix of patient family partners as well as our clinician partners. So I just want to give a warm welcome to everyone. Give me just 1 second. We'll get started on our slides. So as Ro shared, sort of how did what happened? Are you able to see my screen, Ro?
Yes, I can. Just need to make it larger.
Are you seeing my slides?
We are seeing the issue side slide.
There
There
we
we go.
There you go.
Now we're done.
Perfect. I have so many tabs up. Thank you. Um, so as Ro had mentioned in my bio, I was like so many women and birthing people just looking to have a family. And next thing I know, I experienced an amniotic fluid embolism and it put me on a whole completely different journey. So today I really hope to share a little bit more about my own story, starting the foundation, and then really dive into the resources that are available for our clinician partners, as well as it might be of interest to those who've experienced a severe maternal event, who are joining us, or other patient advocacy organizations, about some of the tools that we've developed, really based on the feedback that we've received from our community, both providers and patients and their families. So my hope for today is really to, as you walk away from this, is being able to employ our educational resources. There'll be a lot of links and QR codes that you'll be able to access. And again, we'll share this with you at the end to be able to apply those learnings to really improve either your decision making or how patient outcomes, and of course, how you communicate with patients and families. And then being able to utilize these resources to support the patient and their family during and after these events. So I'm just going to start briefly for the patients and family partners in this group. This is a case study. And so oftentimes when I lecture, and I'll start off with my story. And so we typically provide it in this format just for clinicians to be able to quickly scan and read. But I was 31 years old. This was my first child. I had a subchorionic bleed at 16 and 22 weeks. And so I was placed on bed rest. About 32 to 34 weeks, I was off modified bed rest and returned back to work. And then just shortly after returning to work, I had my first weekly appointment. And when I went to my weekly appointment, I said, something seems to be going on down there. And I had probably a slight tear in my back. And so I was leaking amniotic fluid. I was then told, hey, you're going to have a baby here very soon. We'll see how labor progresses throughout the day. But, if things don't get moving, then why don't you come in the evening? And so I was admitted that evening and was augmented with Pitocin somewhere around, I think 9 o'clock at night. I went in, checked in at 7 and started PIT at around 9. About 5 hours later, I received my epidural. Things were starting to kick into motion. But I want to reorient everyone that this was in 2008. And so we've seen a lot of changes in this space in terms of, I was at a smaller community hospital. We did not have a hospitalist. We did not have any bundles. We did not have mass transfusion protocols. And so I was with a private practice, which meant that the hospital did not have an OB on staff all the time. They did not have a hospitalist program. And so the next morning was change of shift, and I had rested throughout the evening. The next morning, one of the clinical team of the 3 came in to check on me, and he, didn't think that things were kind of moving at the pace that he was hoping for. And so they decided they would put in a pressure catheter to really look and see the strength of my contractions, but also look to see how our little peanut was doing in there with the fetal scalp electrode. So he placed this device inside of me and stepped out of the room. And just moments, really just moments later, I started to complain, apparently that I was having a hard time catching my breath, and had a sudden and acute hypotension where my blood pressure started to change. I started to become a little tachycardic where my heartbeat was beating faster. And our son's heart tones changed as well, and he started to experience fetal bradycardia. The nurse asked for respiratory and the OB to come back into the room. And it was determined as they sort of kind of moved me from side to side that it was best that I have a emergency section. Now, at the time, I was in, again, a community hospital. There was only one labor and delivery surgical suite. And again, 2008, when we moved patients, they decided they were going to take me to the main OR. But before they got the bed out of the room, I apparently vocalized to my nurse that I thought I was dying. I shortly thereafter had a seizure. I was in probably very likely a PEA or pulseless electrical activity, heart rate rhythm. And by the time I made it to the OR, I was in complete asystole where I did not have a heartbeat. I arrived blue, cyanotic. They quickly did a delivery. Our son was delivered within 5 minutes of my collapse. His APGARs were 2, 7, and 9, so he made a rapid recovery. It took a little while for my heart to get back up online, and so ROSC is return of spontaneous circulation. So my heart started again at 11 minutes. Over the course, as I was moved from the OR to the ICU, it was then determined that I was bleeding more than they would like to see. And that's when tests revealed that I was in fulminant DIC. I received approximately 16 units of various blood products.
This
Now,
was
that
all.
is on the lower side for many AFE individuals. I was in I was in a smaller facility, but I also was in a facility where there was another heavy user of blood products in the ICU. It was then determined that they were going to use Novo 7 or activated factor 7 or recombinant factor 7. It can be used, which also helps an individual clot. There was concern. I did have micro or shatter PE throughout my lungs. There was concern that I would develop a DVT, and so they prophylactically placed an an IVC filter. So it is a small filter that goes into your inferior vena cava to catch any potential clots. I was discharged at 7 days, and our son came home 10 days later. He was having a little hard time. He was losing some weight, having a hard time with that suck swallow response, and he had a little bit of jaundice. So he stayed and cooked for a little bit longer in the NICU. And I wasn't reunited with him after my delivery. I was obviously intubated in the ICU and wasn't extubated until the evening of the next night. And I share this picture because this is such a special moment for us. I do have very small memory of all of these events, but my memory, most of this one was we met in a hallway, and my husband and my family by my side, and they had brought our son out to see us, and he was asleep when they brought him out. And I very sort of hoarsely said, like, "Hey, Bubba," which is something that I had kind of said when he was in the womb. And he immediately, like, I guess his little ears perked up, but he immediately started to cry. Um, and what I like inferred from that was, one, just like it was total love at first sight. He had the coolest hair, but also I felt like he recognized me, and I felt like he was vocalizing, like, "Where the heck have you been? Things aren't fantastic." He is almost 17. He'll be 17 in a few weeks, and I promise you, he is still chirping. He is still vocalizing his distaste, which these days as a teen, most of what I do is annoying to him. So it's very prophetic, I guess. I did want to take just a brief moment and kind of share a little bit about AFE facts. Again, for those who may not be providers, just to like understand a little bit more about what amniotic fluid embolism is, because it is especially rare. I think it's 1 in 40,000 is what we estimate it to be. I'm sure that range is not a full estimate, and I can get into why. But if you equate that out to 4 million births in the United States, That's roughly 100 women and birthing people who will experience an AFE each year here in the US. Mortality rates now, when I had my AFE in 2008, mortality rates were really around 80%. And we're seeing those mortality rates come down for a couple of reasons. One is for all the reasons that I've told you, which is a lot of recognition, rapid and aggressive responses, the use of so many great things like mass transfusion protocols, bundles, understanding having ACLS background, ECMO cannulation. There's a lot of reasons I think we've done. I'd love to take some credit for this, but I don't know if I can. But really raising awareness and education around aggressive responses. I think that also it really depends on where we get our data. And so we know that AFE is a spectrum similar to other disorders where you will have cases that have a catastrophic response and some of us who have a more mild response. 87% of all cases of AFE are going to have a maternal arrest. So if you think about that, that's a lot of patients of that 100. So 87 out of 100 are going to have a cardiac arrest. And that is why it is so critical. And I'll get into some of our initiatives of why people need to be prepared. Unfortunately, this is not like what we see on, Pit Med or whatever, all the Pit and Grey's Anatomy, where, people have a cardiac arrest and they come right back. Recovering from or responding to a maternal arrest is incredibly difficult. In addition to that, AFE involves what I referred to as DIC, which is a very complex form of bleeding, which DIC in many cases is often referred to death is coming because of its challenging nature. So when you combine both a cardiac arrest or cardiorespiratory collapse and bleeding, it's no surprise why the mortality rate has been as high as it's been. It is a diagnosis of exclusion. So if we think about people who maybe have diabetes, we take an A1C and we're able to see that on the blood, or cancer. If we think about somebody who breaks a bone, we can see it on X-ray. AFE is a diagnosis of exclusion. So we do not have a gold standard diagnosis, which means that there's no blood test, there's no imaging, there's no way to confirm that this has happened besides excluding anything else that it could potentially be. So this subjectivity makes it really difficult for not only patients who experience this, but also providers who are trying to treat it, because at the time when it starts, we don't exactly know what it is. What is fascinating to all of us and exciting for many in our community is those who are able to survive these events and have their fertility remain intact, where they did not require a hysterectomy or any invasive technologies that can inhibit fertility, is that we have not seen a recurrence. So AFE can happen on your first pregnancy. It can happen on your 10th pregnancy. You can have an AFE and then go on and have another child and it not happen again. So talk about confusing and a head scratcher, which is why we exist. We're going to try and answer some of those questions. Some of you may have heard of it called anaphylactic syndrome of pregnancy, or ASP. I always tease Dr. Clark, on our medical advisory board, that he likes to use acronyms. I think that this name, while it is more descriptive of what AFE is, it is probably more difficult to spell. And it didn't largely get picked up in the healthcare space, and so it can be synonymous with one another. But AFE is more similar to an anaphylactic-like reaction. It's also been referred to as or considered systemic inflammatory response, or pregnancy-induced systemic inflammatory response. Either way, they're all mouthfuls, and it's extremely challenging. I will also add that AFE is unpredictable, so we don't know who it's going to impact. It is unpreventable. We have no way to stop this, and it is untreatable. The treatment to support AFE is entirely supportive, which means that our healthcare providers that are on our call, I think all of you recognize just how challenging this can be, and we hope that through our organization, we can take the uns off of there and make this preventable, predictable, and treatable. So the AFE Foundation came to be. I experienced my AFE in April of 2008. Just a few months later, after coming home, I also want to reorient us. There was no TikTok, no Instagram, Facebook is just getting started. I think most of us were trying to figure out where our high school, love interests were in their lives. So it was a very different time. There was not Google had just come out. We did not have Chat GPT or AI. And so this was a space where we were still doing Ask Jeeves, and it was a unique time. There was no Scopus, there was no NIH, there was no way for us to even look up healthcare or published articles. So it was a very different time. A few months after my event, it was my birthday, and my husband had said, what would you like to do for your birthday? And there's really, after going through something like this, there really was nothing material or anything that I really wanted to do. I really needed some time to go to the library. My background was in biology and chemistry, and I really felt like I needed to go better understand what had happened to my body, and like really understand what the providers had told us. Now, when I was in the ICU and I was just being extubated, one of the conversations that was one of the conversations, and some of the words that were used was, you had this event occur. This is what it's called. Most women die from this. And I then they left the room. And I remember just sort of reading the room and seeing how heavy my family, like I could see the tears. I could see my best friend was in the room, and she didn't live in the state. And so I was like reading the room and realizing like the heaviness of what had occurred. And that had stuck, that seed had been planted, that day. And so fast forward a few months later, I found myself in the library, our local library, pulling up research articles. I remember them being spread out on the desk and thinking, I had sat on a couple nonprofit boards, just for work. And I remember thinking, surely there's like, women shouldn't be dying in the 21st century in the United States. There's got to be like a cause for this. And so, did my whatever search, Ask Jeeves, Google, Yahoo, and came up empty handed. And I thought, that's strange. And so it was there in the library the day before my birthday that I was very inspired to do something about it. And when I kept reading the articles, I kept seeing a similar name, which was Steve Clark. And I decided that, and his name is, on any research article, you have the author's contact information. And I remember calling, because again, didn't have emails because we didn't give out emails. That was like almost as protective as social security numbers. I remember calling, and that he was actually a provider. He was actually an MFM, an OB that was actually providing care, but he also was, did AFE research. And so I got his email. I sent him an email that night and said, I'm considering starting an organization and I want to help with research. I want to know why your research ended in the 80s and the 90s. How can we reinitiate that? And I was in sales at the time. So I said, give me 30 minutes of your time. I'll bring you lunch. And so he responded the next day and said, great, when can you fly out to Salt Lake City? And so a month later, I found myself on a flight. Probably not wise. I had a lot of other health issues that I didn't realize. I flew out to Salt Lake City. I met with him and Gary Dildy, and the AFE Foundation sort of blossomed from that point. They said that they would be happy to come alongside of us and perform our research. And so really, that's when our mission began. Our mission began to reduce the maternal and infant mortality that's attributed to AFE, and then also recognizing that the families, ours included, but so many families that didn't have a positive outcome, and didn't have a survivor in their family or wasn't a survivor, really, I felt like they must have felt so isolated because, again, there was nothing online. And so that's where our initiatives came to be. So one, we have three things that we focus on at the AFE Foundation. Education. The reason why education is first is because we recognize that until we better understand the etiology of AFE, we won't be able to move the needle. But we still need to tell people about what AFE is because it's rare. It's a very small chapter of a small book. And when we think about our physician colleagues, think about their medical school, think about how much they need to know, how much vast knowledge, and how little something that's a rare condition, a 1 in 40,000 in a subset of obstetrics and gynecology. So when we think about our critical care colleagues, our emergency physicians, anesthesiologists, like how much of AFE is in their education, it is teeny, teeny, tiny. When we think about our labor and delivery nurses, obviously their education is far more robust around labor and delivery. And so when we think about education, we have education that is really geared towards the full spectrum of the interprofessional team. So labor and delivery nurses, anesthesiologists, obstetricians, and maternal fetal medicine. And then, of course, we have to think about our critical care colleagues, our laboratory professionals, our emergency room physicians who may be responding to a code, especially in low resource areas or areas that don't have a hospitalist on staff. So our education is our first line of defense is to go out and teach people about what AFE is, how to treat it, how to manage it, what medications are involved, and also how do you communicate and effectively support families as they go through this. The other aspect that we do is our support. I feel like this was something that we did right away. So we started this in July of 2008, and by November 30th, we lost our first AFE sister, Teresa Clark DePietro in Baltimore, and her family came to us, and we were able to walk alongside them and still are very close with them. And they informed so much of what we learned around how to support our grieving families. And so support is something that, we did right away because that was something a lot easier to do, which was to, again, walk alongside and help people navigate their paths forward. The heaviest lift that we have is our research. Research about AFE is extremely challenging because it's unpredictable. It would be very difficult to consent 4 million patients or 4 million birthing people in the country without knowing where they were going to deliver or who they were. And as you can imagine, with the mortality rate, it's extremely difficult to do any sort of research on patients who pass away. Also, because it's a birth-related complication, research around pregnant and infants is something that is a little bit more challenging to do. I'm going to get into all of these initiatives here in just a bit. So I really want to focus first on AFE education. So for those who are patient family partners on our call, bear with me. I hope that you'll see that our stories and the feedback that we get from our clinician colleagues can be so impactful. So all of this education has come as a result of the feedback that we've heard from our community of either 3,000 families or the 5,000 clinician providers who have actively shared information with us in a variety of ways. So the first is our course. This is a 3-hour CNE course. It is a very deep dive into how did AFE come to be? Next year will be the 100th anniversary of AFE. It was first described in the literature in 1926 in a Portuguese journal. It wasn't in an English journal, an English language journal until the 1940s. Both journals were from medical examiners and medical pathologists. And so if you think about 100 years, what have we really come to know? What we've come to find out about AFE was it was largely thought that it was the amniotic fluid that enters the maternal circulatory system and gets caught up, this fetal debris gets caught up in our lungs. It causes this cardiorespiratory collapse. And when we think about 100 years ago and medical pathologists, these patients never made it to the bleeding portion of AFE. And so they really did think that this was something that happened in the lungs, and that was the primary instigator for all the problems. But as we became more proficient with blood transfusion and CPR and basic life support and ACLS life support and medications like epinephrine, all these things that got a heart beating again, well, then come to find out, decades later, oh my goodness, these patients actually develop also severe bleeding, two completely different pathophysiologic cascades. So this course will talk about the historical context and the historical learnings and what we've learned now going forward about what we propose as the pathophysiology or sort of what happens in the body, if you will. We also cover management and treatment, and that will come from, depending on your scope of practice, if you're in nursing or if you are a physician for medication management, it is a deep dive into the management and treatment. You'll learn about our research opportunities, and you'll also have an opportunity to learn more about how to support families, which you guys will all get a preview here in just a few moments. This is a course, there's a QR code. So if you're a provider, please, it is a free course. You'll get 3 hours of nursing education. We do not have CMEs quite yet, but it is a fantastic course to share with your colleagues if you're an educator or if you're involved in a PQC. You'll notice there is no AFE bundle, and that's okay. We'll take the heavy lift on educating around AFE. This course was created in collaboration with an MFM, a critical care and obstetric nurse of 30 years, as well as a simulation expert. So I'm positive the reviews and the responses that we've had to the course is that over 80% of all those who have completed our course have excelled their understanding of the diagnostic criteria, the treatment, the management, the pathophysiology, and nearly 90% of people report that they can better support families after going through the course. So some great feedback. We also have a simulation toolkit. So we know that practice makes, I won't say perfect because there is no perfect in healthcare, but certainly if we think about any golfer, we think about any athlete, we think about anybody on Jeopardy, right? They've practiced over and over and over again. AFE is incredibly complex. It takes a huge team of people to respond to something like this. And being able to work together as a team and teamwork and communication is incredibly important. Our simulation toolkit is very robust. It is approximately 40 pages. It comes with everything you could possibly dream up on how to perform a simulation in your healthcare facility. And that can be either low fidelity, which means maybe they're just using a chest mannequin, like what you see in a BLS class, like a basic life support class. You would just see a chest of a man, usually it's like a very fit dude. I'm not quite sure why we don't have, a belly with large breasts, but nonetheless, you can do low fidelity simulation, which is just learning how to do hands-on chest and how to do CPR effectively. Or you can have high fidelity, like what you see in this picture, which is essentially, and they have them now with AI, they actually talk, they do all sorts of things. But you can also, this simulation toolkit also works for mannequins. So it comes with everything that you need to program the mannequin. So again, it's really designed for facilities that have maybe a low resource facility or a facility that is in a less populated area to even a very high university setting where they have entire simulation labs. So I'd love to take a moment to just kind of show a little bit more about what's in that simulation toolkit, just because for our providers on the line, I just want to kind of have you oriented with what it includes. So inside is obviously we have you can see it's very comprehensive, but what I really want to draw your attention to is our checklist. Our checklist is something that can, so I'm just going to scroll past here. This really gets into just how to use this toolkit and metrics. I think one of the hardest things about simulation is how do you know if it's effective? And we have over 100 different metrics that you can employ in using this simulation toolkit. It talks about how to a scenario. So we have listed, I'm just going to get through here. So it has pictures of like how to set up. Here's a great example of just like a chest trainer where you can set up practice stations. We also have videos that accompany this. But what you'll find is if you download this, and I'll go back to the QR code, you can share this with your clinical educator or your simulation team. But you can also become familiar with the different metrics. So even if you're not the educator or the simulator, I would encourage you to download the simulation toolkit just to kind of browse through it and see what really responding to an AFE entails. Part of this toolkit, and this is what I want to draw your attention to, is our checklist. This is a stabilization guide. This is something that will be emailed out to all of you. It is something that you can laminate and put on your crash carts, but it is the 3 B's of AFE. And this came about from our colleagues at Clinical Concepts in Obstetrics. They wanted to distill AFE down into something a little bit more simplified because it can be, the pathophysiology is complex, but the response to this is quite simple. These patients have challenges with their breathing, and so getting oxygen to their tissues. They have challenges with their blood pressure, also challenging to get blood and oxygen out to the tissues if your heart is not beating or beating too fast and it's not efficient. And then also if your heart stops. So you'll see here, these are the responses that you'll take if you see changes in breathing, changes in blood pressure, such as a declining blood pressure or cardiac arrest. And then of course, this bleeding area is something that I think many institutions have done such a great job with. If we think about mass transfusion protocol or the postpartum hemorrhage toolkit, when we think about our hypertension bundles, you've done a great job of learning about blood pressure. It's just that when they happen all at the same time, it can be very overwhelming. Well, look at that. Look at my little computer doing fun things. We're going back to here. And so this is something, again, where you can put it on a crash cart. It can be used as a treatment algorithm, but it can also be used, again, different metrics. You can also use these different these different tasks with saying, like, how fast can you get the room prepared? If you're going to call a code, what do you need to do to the patient and the room to prepare for the team that's going to come in? These can all be measured. How fast can you pull the crash cart to the bedside? How fast can you move the bed away from the wall? And how fast can you set up a backboard and set up an ambu bag? These are all things that are really great things that are really low resource that you don't need a lot to do to practice. It also comes complete with a checklist or a planning guide. Putting together a simulation, it can take a while. And so, hey, if you know at the end of the year you want to do something, or AFE Awareness Day is coming up March 27th, if you want to do something, these are the tasks that you need to do. And we've given it, to plan even a year or 6 months out in advance. We also have created a scenario overview and the scenario of how do you set up the presets for the mannequin and how do you set up the room. It also includes a scenario. It happens to be my own scenario, just because we had that information readily available, but you can use any patient scenario. If you've had an AFE in your facility, you can go back and use that same one. Here's just a scenario and a guide of how you can set that up. And then, as I mentioned, we have different metrics and debriefing points. We have an agenda. So when you bring your course in, this is a hyperlinked agenda where you can change it to all your times. But we've tried to really take away any heavy lifting that you need to do. We have a supply list, where you stand in the room. This is something really simple that you can adopt when you are in a room and you're doing a resuscitative delivery, or you have an AFE patient. Where is who's standing at the head of the bed? Who's here at the chest? Who's here helping with delivery? And what are some of the other zones? What's your zone and what are your primary responsibilities? And then, of course, we have a feedback template. We'll get back to our apologies as I navigate through this. So again, that's our simulation toolkit. You can do the QR code here, and that will take you to our website where you can download it. We just ask a few questions, mostly because this was funded by a grant, and we need to be able to identify how many people are using the simulation toolkit and how many people could potentially be educated through that. Again, here is just another quick view of our checklist, a QR code if you would like to download that, but we'll make sure that everybody gets it. We do have a hotline. This hotline is also for our providers. It's 307 end AFEs. It is a warm line where you will always get a human that answers the line. They will ask you quickly if you are a healthcare provider, if this is an emergent situation, and they will patch. They will send a notification to our team that oversees this hotline. We will immediately call you back within 30 minutes and respond. Usually it's within 5 minutes, where you'll get one of us on the line who will walk through what exactly your needs are. So you could need clinical guidance, you could need crisis support, you could be reporting a case. We will not ask for any HIPAA information, any patient identifying information. We are really there just to assist you. So when you think about calling a rapid response or calling a code team, have someone step out when you have extra hands. and give us a call. We are there to assist in a variety of ways. We also talk about communication. As I sort of shared with you, it's really difficult for patients' families. It's really difficult for patients to wrap their heads around something as complex as AFE. And I can imagine that as a healthcare provider and you've gone through an event such as this, it's not only jarring, it's actually traumatizing. We talk a lot about second victimization. This isn't second victimization or vicarious trauma. This is actual trauma that happens when you are a provider in this space. While you may be stress inoculated for stress because your jobs are stressful, you're not necessarily stress inoculated for a maternal cardiac arrest and life-saving measures, which means that watching a patient code can be extremely distressing, and it can activate your autonomic nervous system. As a result of that activation, you can have a decrease of executive functioning. So when we say, hey, you go from providing immediate supportive care, like hands on chest or pushing medications or emergently delivering a baby, and then we need you to come outside and talk to the family, that's a big shift. That's a big transition. And so with that transition, and recognizing that maybe you have word recall issues, maybe you want to avoid, and maybe you have a complete blackout of the event, trying to come up and organize what you're going to say. So we've come up with a mnemonic. So in healthcare, delivering bad news is extremely distressing for providers. Just in the setting of like trauma or the setting of cancer, we recognize that a lot of the mnemonics that are out there, like spikes or sunburn or even SBAR, is something that you could use. It doesn't account for the emotions that are going to take place, not only from the provider, but also from the patient and the family. So most communication guides, like spikes, will say, prepare for the patient's emotions, but it has nothing to do with like really acknowledging that you can have hurt from what you've just witnessed. So we came up with AFE for AFE just because we want to keep it simple. So one is that we acknowledge our emotions, allowing yourself to express yourself, to work with your colleagues, to take a pause and say, am I ready to go out and have this conversation with this family? Or am I ready to be part of the team that explains to this patient what happened to them? Formulating a plan. Again, it can be very difficult. How do you talk about AFE when maybe you don't even fully understand it? It's very difficult. So what we've done is we've created several different tasks, like, okay, identify what are the main clinical points we want to communicate? What do we need to talk? Do we need to assess the patient's, readiness to hear this information, the family's readiness to hear this information? Is there a language barrier? There's a lot of things that you need to do to come up before you run out and have a conversation with a family, or before you share with a patient as they're maybe being extubated or weaned from medications. How do you tell them what's going on? And then of course, executing the communication. We've all been there. I'm probably there like halfway through this lecture, is, like executing the communication. Sometimes our words don't come to us. How do you put AFE in lay language? Well, we've taken care of all that for you. So we have these beautiful checklists that will guide you through this process about how do you communicate. They're set up in 4 unique settings. So in a crisis situation, when a loss occurs, how do you deliver bad news to the patient? Meaning, this patient did not anticipate having an AFE, obviously, and now she's waking up in the ICU, or they're waking up in the ICU, and you need to tell them what this is. And then discharging the patient. That's when we have this like strange and unique setting where the patient may have a feeling of gratitude to be alive, but also frightened and disappointed and scared or traumatized. And then you have a clinical team that has just truly done an effective and amazing job, a Herculean effort to save this patient's life. They know that it was, a very precarious situation. And so they're celebratory. Like, this is what you worked so hard, is to be able to have this situation happen and be able to save a patient or be able to save their baby. And there is this sense of like relief, and this patient finally gets to go home and, carry on with their lives. And yet the patients are feeling like this is just their day one. And this is definitely was not part of their birthing plan or their pregnancy plan. So we've really tried to see, based on the feedback from our community, about how we can guide these communications to essentially reduce any additional trauma that may happen as a result of communication. We all know that how we communicate is just as important as how we treat, how we clinically treat a patient. We've developed a crisis handout, and talking with many of our families, our grieving families, and our families, our dads, our widowers, is sort of this like overwhelming nature of like when they're told what we believe is happening. So we have this crisis handout. It is a one page, but front and back, or 2 page if you're printing it at the hospital, which just basically goes over the key, the key questions that most people have, like, wait, what is this? We have no idea. We've never heard of it. How do we even say it? How do you prevent it? How did it happen? How do we diagnose it? Like, how rare is this? You're telling me it's rare. How rare? The survival rate. We don't know if my loved one's going to survive. What's the survival rate? And then what are the quick tips that people need to do? Like, if this patient's family has another child at home, this patient is going to be in the hospital for a long time. This is not something, they're not going home in 2 days. What do you need to do? Who do you need to inform? We've all known about the telephone game. Imagine how difficult it is for a lay person who doesn't understand amniotic fluid embolism to then have to call maybe their in-laws, maybe their loved ones, maybe their best friends, maybe their own family. How do we expect to tell them this information when they're under duress? Maybe they've witnessed their loved one collapse, and now we're asking them, they need to go call and tell everybody, I don't know what's going on, but you just need to be here. So what we've done is we've created a QR code. They would just scan this QR code right from this paper. It populates the same information onto their phone, and then they can text that and say, this is what we believe is happening to our loved one. We really could use your help and support. This is where we are. Could you please come? Or stay tuned for more details. We also gently tell them that there may be opportunities for research, and this is just a very subtle way of letting them know, hey, your healthcare provider may talk to you about research. Rest assured, this is safe, and nothing more needs to happen to your loved one. We also just gently let them know that our organization was created by AFE families and is created for them. And so on the back is a place where, as you can imagine, we all have phones, but we often don't have pens and papers. And sometimes we don't know people's names. And so imagine if you're on the care team that's going to go out and effectively talk with this family, just having them be able to write down, okay, this is who your ICU team is going to be. This is who your labor nurse was. This is who your OBGYN is, because sometimes it's not the OBGYN that they've seen. And so this is a great place for them to be able to take notes, or if they have any questions, like, when's the next time I'm going to be able to talk with you? I've had several questions in my head come up, and I don't know who to ask. This is a great way. So you can print this on our website. Everything we offer is free. Our course, our simulation toolkit, everything we offer is free. Everything is printable. Everything is downloadable. And all you need to do is download it and hand it to them. If they need also to call our crisis line, we have 5 LCSWs that are on staff and available to us, where we can immediately do crisis support for them as well. We also have a survivor clinical summary form. This is something that, based on the feedback of so many of us, when we're in the hospital, like anyone who's had a severe maternal event, we see a lot of ologists afterwards. And many of us are not conscious during our care. And so how do we effectively go on to our primary care provider that we haven't seen in 9 months? How do we go see a cardiologist, a hematologist, a nephrologist, a psychologist? Like, what happened to us is impactful, but it also has lasting health implications. And so if we are lay individuals and we have not been conscious for our care, imagine how difficult that is for continuity of care. I'd love to think that everybody has access to Epic and Cerner and all the electronic medical records, but that's not always the case. And so this clinical summary form is something that we devised. It's 2 pages. And what it does is it goes through and explains, this is something that you can provide to the patient and their family. It is written in clinical language because the intent of this is to allow them to take this to their next physician's appointment. So it can be a quick distilling down of what interventions were done for this patient, how sick she was, and some of the prompts that we want to talk about, like checking in on her mental health. So for an example, like, I didn't know when my baby was born. I didn't know how many pounds he was. Like, I didn't know any of that information. I didn't know about all these other things that had happened. So this is something that the labor and delivery and critical care team can come together and complete. It is a PDF fillable document. So it's usually just a lot of clicks, and then you're good to go. But it talks about like how many transfusions did they get. This is really important because what if this patient develops Hashimoto's or Sheehan's? It's also important for us. Families are really keen on giving blood back, recognizing, as I shared, I had 16 units, so doing replenishment blood drives or memorial blood drives. This is a great way for them to better understand exactly how many products were used. There's also a way that captures like what surgeries or interventional radiology, like uterine artery embolization, what things were instituted to care for this patient. On the back side, it goes into also goes into mental health assessment just to ensure that this patient isn't showing signs of postpartum depression or postpartum anxiety, postpartum psychosis. It also goes into a hysterectomy. Understanding the type of hysterectomy that was done and a gentle nudge that says, hey, don't ask this patient about when her last menstrual period was. So you can imagine an unexpected hysterectomy is something that can be quite emotional. So this form was really created to help, again, in the continuity of care. Forgive me, I'm on the brink of getting a cold, I believe, so forgive me. I talked about how we support our patients and our families, and so I just kind of want to transition into what we do to support. We have a very comprehensive, excuse me, I'm so sorry, I'm going to mute. Goodness, I am very, very sorry about this. What poor timing. Our survivor guide is something that is really an amalgamation of the stories that we have heard from so many in our community. I was going to see Courtney Johnson. Are you on the call? If she can be
I'm here.
Courtney, would you be willing to walk through this, just the verbal? I'm so glad you're on this call. As I go through the pages, it gives me a chance to cough. Gosh, I'm so sorry. Will you take over for me?
Yeah. Okay, so then discussing the survivor guide. This is a guide that I wish I would have had at the time of my AFE. This describes what the foundation is, what can occur after you come home, as far as being able to process your own feelings and thoughts. Some other survivors' perspectives is not in detail, but as far as seeing other survivors and seeing what they've gone through, the percentages, kind of, I'm zooming in here a little bit. How does it affect you? How will it affect your families? The understanding of physical and what's happened to you. This was the big one. That one was a big one, trying to physically understand and mentally process what had just happened. Adjusting to your body. Some things that can happen. I know I had thinning and hair loss, and when I reached out to the community, that was one of the first things that I asked because I had lost a significant amount of hair. So that was nice to have that knowledge. Some things as far as birth trauma, the percentage of how it happens with new mothers and experiencing birth trauma to parents that have already had a child to then having an AFE, which is what I had. Postpartum and postpartum depression and mental health. Some of us have PTSD, PPA, PPD, which is very common with a lot of patients in general, but especially with patients that have birth trauma. How to find a therapist, which was big. My medical center was very thorough when it came to telling me you will need one. So some medical centers may not have the same verbiage and the same resources available. So they offer that in the guide, and some common challenges and learning how to cope. And some common triggers that can come as far as when it comes to your mental health or some of your physical health. So this breaks it down for you perfectly, and how to manage the anxiety and try to help make appointments. They really do a phenomenal job in this guide on trying to help the survivor come to realize and try to help that whatever they're feeling, whatever they're going through and exempting is definitely normal and to be expected. Because when you do come home from an AFE, and again, it is rare. It's not something you can go to your neighbor and say, hey, thanks, can you talk to me about this experience, right? This guide will walk you through it, and it'll make you know and help you know what you're experiencing is normal and all the feelings that you have. Some survivors will go back to work, some will not. So this guide will also kind of help with you if you are a patient that would go back to work. This would help you also kind of discuss those feelings in that as well. And then it also allows you, that's something that's very therapeutic as a survivor or a grieving family, is sometimes being able to give back. It's called Be the Light. So something that's very therapeutic for patients. You may have this in your medical centers or not, but you, as far as a PFP, a fellow PFP, being able to go back to your medical center or your state medical centers and discussing with them your experience and being a part of not necessarily their training, but as far as being able to speak as a lived experience. If you have a patient that would like to do that, that's wonderful for the medical center and the training, but it's extremely therapeutic for the patient as well.
Thank you so much, my sweet AFE survivor sister, for jumping in there and doing such a great job. Nothing better than hearing from our community, how AFE has impacted them and kind of some of the resources that we've put together to guide them as they really navigate their journey going forward. We have another side of our community, and I know we're getting close to time, which is those families who aren't as fortunate as Courtney and I to have lived through something like this. And so we have put together a beautiful memorial book. So if you have a loss and you have a loss of a patient or a loss of an infant, to this, our community is very loving and very supportive and will welcome any families with open arms. We have a variety of ways that we honor our angel sisters. We have a collection of memories. This is a hardbound book that we created with the support of licensed clinical social workers about, imagine that a woman has passed away and her child doesn't know a lot about her. So this is a book that can be completed by family members, spouses, friends that are just beloved memories, inside jokes, family lore, all of that stuff, so that when they are older and it's age appropriate, that they can read a little bit more about their mom from various perspectives. Again, all these resources that we do, we offer a grievers box. So we send a box as soon as we are notified. We send a box to the healthcare facility that supports them with a variety of lavender scented things and comfort items. We send a box to our grieving families, and we also send a box to our survivors. We offer a candlelight vigil every year on our AFE Awareness Day, which is March 27th. And if you're joining us, we'd love for you to join us. We also do special things like down here on the right, you'll see this beautiful, for our healthcare facilities that lose a patient, and you would like us to help acknowledge that patient in your facility. We provide these custom made, beautiful wings that represent the life that was born and the life that was taken in a facility. We have custom made candles, memorial candles, and then we also offer a lot of attire and apparel that has the names of the families that have reported the loss of their loved ones too. We do offer AFE research. We have a bio repository and a registry. Really what this just goes to show is that our community is helping move the needle. As I shared, our goal is to make it preventable and predictable and treatable. And the only way we're going to be able to do that is through our biorepository, either in reviewing cases or studying those that it's happened to. So we have specimen studies underway. We hope to do a genetic study in the future. But these are, again, great ways that patients and their families can also give back. Similar to like organ donation, this is also something similar where you can contribute to our repository. When we started this organization, just to do a genetic profile, it was, almost nearly $100,000. Now you can find out the DNA of your dog or cat. And so it's become much more affordable. And we believe that our community is the best way is to study us. And so we hope that here in the very near future, we'll be able to do a genetic study to see if there are any predispositions that we have to an inflammatory response like AFE. And then I just share this picture of like where we are today and how impactful these other events are to an entire family, but also how impactful they are to those who are providing the care. So during my care, my husband became very intrigued with the NICU, with our NICU staff and our ICU staff. He actually decided the same time I was going back to the library to start the foundation, he was inspired to go back to school and become an ICU nurse. So he is working as a supervisor in the ICU where I recovered. And this is our son on his 16th birthday, so it'll almost be a year ago. He is healthy, he is thriving, and this event, this single event of his birth, completely changed the trajectory of our lives. And we are especially grateful for the opportunity to, one, be here, but also to work together hand in hand with the clinician colleagues and our partners at Mama's Voices to bring this education and these resources to light. So I thank you all for your time and attention. And to healthcare providers, thank you is not enough for all you do. And to our colleagues, either in organizations or families that have been impacted by this, stay the course. Thank you for being involved. And it's really up to us to help move this needle. And then I can open it up for questions if we have time. I'm happy to stay on. I know